today and not on campus. So therefore I'm coming from Port Perry, which is on the land of the Mississaugas of Scugog Island. I'm, as Peter said, the acting chair of department, and so I would like to extend a very warm welcome to Jennifer from all at Health Aging Society, the faculty, the students and the staff. We're honoured to have you with us and very much looking forward to what you've got to say. Jennifer Walker is a member of the Six Nations of the Grand River. She has a PhD in Community Health Services, specifically focused in epidemiology from the University of Calgary. Dr. Walker's work is on Indigenous community-engaged health research and focuses in particular on aging and dementia. She is a core scientist and an Indigenous health lead at ICES in Ontario, and she also leads a substantive Indigenous cognitive health program of her own. Today, she intends to consider the impact of colonization and colonialization on dementia in Indigenous peoples. And she wants to consider opportunities for improving cultural safety in dementia assessment and care. Take it away, Jennifer.
Thank you so much. Thanks so much for welcoming me, and you know, and for I feel sort of welcomed to McMaster. I'm relatively new to McMaster, having started last July at McMaster, and you know, so I'm still getting to know people, and this is a really nice way to feel welcomed. Thank you also for the introduction. I'm also a mother, so hopefully my children don't make that nice and known by running into the room. But such is life with working from home. So I'm happy to be here. I'm happy to sort of have an opportunity to really explore a little bit about the Indigenous perspectives and experiences of dementia, and to share a little bit about that, that unique perspective and the unique experiences that Indigenous people have had that influence their risk for dementia and their experience of dementia. I also want to talk a little bit about the challenges of identifying dementia in Indigenous populations. So I'm an epidemiologist, and I often want to understand the sort of scope and you know, the prevalence and the incidence, and how it's quite challenging for many reasons that also intersect with colonization and a fragmentation of services and data systems that make it hard to identify dementia and track dementia in Indigenous populations. So that's another thing that I want to talk about a little bit. And then also to identify opportunities to improve cultural safety in dementia assessment and care. So those are the things I'm planning to talk about today. I'm going to try and leave lots of time for us to have discussions and questions. So feel free. I'll try not to get distracted if you start putting questions in the chat, but feel free. Like I really hope we can have a good, vibrant discussion and conversation. So thinking for a moment about cultural perspectives. So there's lots of different kinds of perspectives we could talk about that Indigenous people and experiences that Indigenous people have with cognition, with dementia care, with aging overall. But some of the points that I want to talk about that come from this, we did a literature synthesis on cultural perspectives that have been published. And really, one thing that I really want to emphasize is that there is a diversity. The diversity that we have in Indigenous cultures and nations and ways of knowing, languages, all these things, this diversity across Canada, the United States, the world, that diversity is also reflected in cultural perspectives on dementia and the experience the experience of changing cognition, the experience of aging. And these things can change over time and evolve and are impacted, cultures are impacted, and can change over time. So I want to emphasize that diversity, because there are some things that sort of come out as you sort of summarize what cultural perspectives on dementia look like, but they're not universal. So you may work with an Indigenous community that feels the complete opposite way, to the sort of generalized notion of how Indigenous people and Indigenous cultures view dementia. But one thing I'll start by saying is that many people say that Alzheimer's, and sort of dementia as we know it, the medicalized versions, are new, that those are new to Indigenous cultures. People say they didn't have that a long time ago. At the same time, people often perceive dementia as a natural part of the circle of life. So there's a melding of, sort of the natural processes of aging and the understanding of dementia in that process. So on one hand, it can be considered quite a natural part of that cycle of life, and on the other hand, it can be considered quite foreign to the natural cycle of life. So there are these dichotomous views often held in the same community that about dementia. So it does lead to, just even within a community, that diversity. In some Indigenous cultures, and particularly a lot of the work that I've been personally involved with Anishinaabe and communities in Ontario, they describe dementia as a returning, you go through your cycle of life and return to the stage of infancy. So it's sort of like this door, you're going back and you're entering a doorway, and there's that sort of gray space between being older and being an infant, and so in that circle, it's a return to a stage of infancy. So sometimes it's described that way, but I'll say, that understanding of dementia and that interpretation of this of dementia is not universally shared. There's another group that had reached out for some conversations around dementia and cognitive assessment, and expressed that any reference to that had to be taken out of any materials, because for them that was not consistent with their understanding of aging, of a cycle of life, and of dementia. So there is just really no generalizing. And there is this there is a general lack of information that people talk about dementia risk factors, symptoms, progression, treatments in First Nation communities specifically, but it also have heard that from Inuit communities and also Métis Nations, just the lack of specific information about dementia. And so, there's lots of space for more information, both from biomedical understandings and cultural understandings, to better understand dementia. Some of the work that's been done to help people understand what their experience might be like if they end up with a diagnosis of dementia. This is an example of a fact sheet, this pathway that was developed. And you can find on this, you see at the bottom, it says I-care with 2 A's. There's a website, icare.ca, that has a lot of information and tools that are the final products of research projects that have been done with community, and so this was one of them that was developed from work that happened mainly I'm thinking mainly on Manitoulin Island. I was part of this final design, but the research work happened before I came in touch with the group that was working on this. But you know, with a lot of advice from elders and knowledge keepers, this idea, instead of a circle, of a path, this journey of having dementia, and the journey that you'll go through with that diagnosis. So I wanted to put this up here to show an example, and this and to draw your attention to the iCare resources that are there, that you can download, and there's lots of information on that website. But you know, overall, this priority has come from Indigenous communities. This priority to look at and start to think about dementia in Indigenous communities has come from Indigenous communities, and they're really, you know, globally, there are higher rates of dementia among Indigenous populations than general populations. In Canada, our data is really spotty. We don't have a lot of really strong, a lot of strong research or even surveillance work that's been done on this, and there's wide ranges. I'll highlight here that there's more information about First Nations populations, but the range is really wide, but of the prevalence of dementia. The challenge is, of course, there's very different methods that are used for these estimates. But so here's the range for First Nations populations. There's one estimate for Inuit populations, and it's kind of a midpoint of the First Nations one. One estimate that we could find of Métis populations, and then and how that fits in with non-Indigenous populations. And this is like, so it's likely higher for some First Nations and Métis populations. Looks like it will be higher. And in one sort of more detailed look that we did with Alberta data with First Nations, it was about 34% higher for First Nations populations than it was for general populations. And some of the patterns were different. So some of the patterns showed that that the population with dementia was younger, about 10 years younger in general than the non-First Nation populations. It also showed that while in the general population, more women than men, like the prevalence is higher in women than men, in the First Nations population, it was more similar or higher among men, depending on the year. So there are differing patterns. And so there is something we really need to understand about risk, you know, younger ages, and that's consistent with many other chronic conditions and other things that happen in Indigenous populations at younger ages. So that's, you know, it's not surprising, but it is something to note. But then also that pattern that between men and women may be different. So we have this. The risk is likely higher in Indigenous populations and higher at earlier ages, and that's sort of these patterns that may be different. So this is like globally, this report. If you're familiar with dementia research, you're super familiar with this image, because it gets a lot of traction around the risk factors for dementia. So this is overall what the science says about risk factors for dementia and what we know about things that may be present at birth. I'd argue we should go a little bit earlier than birth, but about early life, midlife. So these are like talking about the modifiable and non-modifiable risk factors from a very classic like risk factor way of thinking about it. This is what we know. So it's important to know that diabetes is a risk factor for dementia, that social isolation, physical inactivity, depression, and smoking. These are things in later life that do affect a person's risk of dementia. In midlife, so going a little bit further, I had to break this in two because it's really tall and long, and I needed to break it in half. So if you look at it online, you'll see that it's all one, and I just had to break it up. In midlife, hearing loss, and look at the size of that risk compared to many of the others. Hearing loss, hypertension, and obesity is really important for the risk factors for dementia. And education, like, you know, if you think about how important diabetes might be, or physical inactivity, but then education, 8% in terms of this modifiable, the percentage here says it represents the percentage reduction in new cases of dementia if this risk is eliminated. So this is, you know, this is important context to thinking about why we might have higher rates of dementia in Indigenous populations at younger ages, and maybe the patterns look different for men and women. So these are clues, right? These are important things to know. But I want to take us back a layer from that. Like, this is so classic epidemiology, and I want to take us to a different level to think about determinants of Indigenous people's health. So, you know, we did this little review to look at what the evidence looked like for Indigenous populations in risk factors, that same kind of like, but we wanted to frame it in a different way. We wanted to frame it in terms of what we know about the determinants of Indigenous people's health. Like all of those things are up in this, in this model of thinking about determinants of Indigenous people's health. The most proximal determinants, the determinants that are closest to the outcomes, are often, we have this model of thinking of them as the crown of the tree, as the leaves, the really obvious part of the tree. And those things like our education, and these kind of your environment, your working conditions. So these are the social determinants of health that often we think about as determinants of health. But in this model, we also think about the health of those leaves and those branches of the tree really being determined by the health of the trunk of that tree. And the health of that trunk of that tree is the health of the systems that support all of like early childhood development, income and social status. So what are those systems? Like the healthcare system, education and justice system. And we know that Indigenous populations are impacted by a lot of fragmentation of systems, a lot of injustice in systems, and racism, structural racism in systems. And that these systems are not usually Indigenous self-determined, right? These systems are often imposed, and this is the experience of colonization, is that, there's this jurisdictional divide between the federal and the provincial and the municipal and all of these things for systems. And then the health of that trunk, which determines the health of the branches and leaves, is ultimately determined by the health of the roots. And that's those distal determinants of health, the ones that are furthest from the obvious and the outcomes, but are the main source of health, right? They're the main source. They're the ones we have to deal with first. And those distal determinants are the ones that are the most impacted and fragmented due to colonization. So the historical, political, ideological, economic, and social foundations of society are the things that ultimately impact. So putting low educational attainment, head injuries, diabetes, alcohol use, putting those things into context of these determinants of Indigenous people's health. And when we tried to say, okay, what do we know about, when we tried to look at the literature and say, okay, what do we know about risk factors for dementia in Indigenous populations? The main thing is we know pretty much nothing about these kinds of things in relation to dementia. Like, that's not how people study this. That's not how people think about it. And so this is the context that we need to be thinking about, how we address risk and prevention, how we address how we think about self-determined approaches to addressing dementia. So just to take it just a bit more clearly, like the idea that governance structures, Indigenous identities, worldviews, Indigenous languages, cultural traditions, family structures, those things all come together really like to create the health of these roots. That is what creates the health of these roots. And when those things are rooted in self-determined Indigenous identities, worldviews, languages, then the health of those leaves becomes apparent, right? But these things have been deliberately disrupted, like deliberately hacked. Those roots have been deliberately hacked by a few key things. I mean, many, many, many things, but I'm going to highlight three. One is the Indian Act. And you know, John A. MacDonald says the great aim of our legislation has been to do away with the tribal system and assimilate the Indian people in all respects with the other inhabitants of the Dominion as speedily as they are fit to change. So hack, 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 hack. That is the purpose of the Indian Act, is to do, the great aim of the Indian Act is assimilation, is to take these things away. Residential schools is another vehicle by which these things were disrupted. So in order to educate the children properly, we must separate them from their families. Some people say that this is hard, but if we want to civilize them, we must do that. Again, the purpose is to disrupt family, to disrupt governance structures, to disrupt the knowledge of Indigenous populations. And, you know, this is not ancient history. So the same people, the same very people that, you know, I will sit in a room with to work on developing a culturally safe cognitive assessment, those same people went to residential school. So when they're advising on how to improve cultural safety, they're always thinking about that. They're always thinking about how the assessment will make them feel and will make their loved ones feel in relation to their experiences at residential school. And it's very, very impactful. And I'll get into that a little bit more when we talk about cognitive assessment. And the third thing is the treaties. So, you know, we have like early peace and friendship treaties. You know, we talk about the two-row wampum. We talk about these ones that were sort of built in a time when we were talking about sharing and sharing of resources. That changed and shifted to these, they were really, the purpose of them was control of economics, control of resources, and settling the West, you know, like going from place to place and really, like, again, disrupting these, this grounding, disrupting those roots. So I wanted to go through that a little bit just to contextualize what we know about dementia and those experiences of dementia, because every time I work with, you know, as an epidemiologist and health services researcher, I don't just work on dementia, right? So people will come and say, can we work on HIV? Can we work on diabetes? Can we work on heart disease? Can we work on, so just like to get access to data, to try and like create a sense of Indigenous data sovereignty, making sure that the right leaders have the data they need to make the decisions they need to build their to take care of their nations. And every time, it doesn't matter what we're working on, it comes back to this. It comes back to this disruption of identity, worldviews, languages, cultural traditions, family, governance structures, connection to the land. Those things always impact, because they impact the roots. And so it's really important to recognize that. Those impacts didn't end with ending residential schools. You know, you can see here this sort of like, you know, the relationship between residential schools and treaties, because you can see in the areas where there's like the numbered treaties, how many residential schools were there to just kind of get people out of the way to make room for that economic and resource control. So that point, but also just this idea that this is a quote from a child of former residential school students, that it visited us every day of our childhood through the replaying over and over of our parents' childhood trauma and grief, which they never had the opportunity to resolve in their lifetimes. And so this is like, it doesn't, you know, when the generations of individuals who attended residential school, you know, pass on, it doesn't mean that trauma hasn't still passed on from generation to generation. And really, like, what we need to do through self-determining approaches is to shift that narrative from intergenerational trauma to intergenerational healing. And we can do that by, and we can support that. All of us, every one of us on this call can support that by really like orienting ourselves to Indigenous self-determination and sovereignty, and to not interfering, and to doing work that promotes self-determination and sovereignty, because that is the roots, right? So, you know, of course there's work to do up in the leaves and branches. Of course there's work to do on economics and literacy and all these, and education and employment and things like that. But we have to do it without stepping on the roots, right? We have to do it while still supporting the health of those roots, which is, you know, bringing those pieces back together. So you can track, it's very interesting sometimes to go and look, there's different places, different trackers to see how we're doing on the 94 calls to action the Truth and Reconciliation Commission put forward in 2015. And it's really helpful, I think, to know that, and to be super familiar and in tune with those calls to action, and also the calls for justice from the Commission on Missing and Murdered Indigenous Women and Girls. So this is, I've been saying this a few times, so I won't say it one more time, but just this like importance of self-determination and that shift from trauma to healing. So now if we think about, so we talked a little bit about why those rates might be higher. We have that disruption of the roots. But, you know, when it comes to thinking about dementia and really understanding what those patterns are, understanding who needs support in a community, which families, how do we provide the sort of safe assessment experience and support, it's pretty complex, but that doesn't mean we don't do it. So some of those challenges that we've really seen is that there is a lack of culturally adapted and culturally safe cognitive assessment. So if you can't safely assess, then you don't know, you don't know who is struggling with cognitive impairment. You can't tell if that struggle with cognitive impairment is dementia, or if it's not dementia, if there's not good assessment. So a lot of the foundation has to be on culturally safe, culturally adapted cognitive assessment. It's also hard to find, to have like a, population level look at rates of dementia in Indigenous populations, because there's so many jurisdictional and geographic and cultural barriers that prevent Indigenous people from accessing health services. So if we're looking at health services data, the data may not accurately represent the experiences, and that's the case for most any Indigenous data. There's also difficulties identifying individuals who are Indigenous in administrative health data. And that's a whole other area of work that I work on, in terms of making sure that if we are identifying Indigenous people in administrative health data, that it is done in a way where there's strong Indigenous governance. Like, it shouldn't be for anyone else other than for Indigenous leaders of the nations that are involved to use the data for the purposes of self-determination and sovereignty and healing. So, but it is challenging because there aren't embedded identifiers. It may be even more challenging if there were, because then the identifiers might be used for all the wrong reasons. But when we're working with an Indigenous government that wants to be able to identify their own populations, it's actually really challenging to do. So that's one barrier. And then the fourth barrier is that the definitions that we often use in large data sets, where we say, okay, well, if a person comes to the hospital and gets a diagnosis of dementia, or if they get a diagnosis of dementia from their physician, or if they're on cholinesterase inhibitors, and so that's an indication that they have dementia, those databases are often used to look at dementia prevalence. That's basically what the Public Health Agency of Canada uses to look at patterns and trends of dementia. But for Indigenous populations, they might not work, right? Because we've tried using them before, but they're so restrictive. You have to have actually not only seen a doctor, but you have to have had a diagnosis more than once in a certain period of time. Like, it's unlikely for many Indigenous communities that they have that level of access to physician care or to hospitals, that they're, that's in some places there's like big gaps you just wouldn't see, you wouldn't find people. So taking up just that first one. So, my whole purpose in life, I'm looking at all of these different things, but just thinking about that first one, why is it important to have an Indigenous specific approach to cognitive assessment? Those cognitive assessment tools, right from the start of the work that we've been doing on this, both the physicians and the nurses in the communities and the PSWs and the families and individuals who are being assessed all said these tools don't feel good. They don't feel right to us. Physicians are like, we can't even use them. We have to kind of modify them, but then we don't know if they're doing what they're supposed to do. And so they don't take what they need to take into consideration. So the two things that could be happening is that people don't feel safe in the assessment, so they're not being assessed. Maybe they're afraid of what's going to happen if they are assessed, and they have to, leave their communities to go to long-term care, or, there's lots of reasons why people wouldn't want to be assessed. But so then they're missing diagnosis. But then the other thing that we often hear is that people are being diagnosed with dementia when they don't have dementia. That an assessment might contribute to a diagnosis. Or they're screened, they're not meant to be diagnosis. The only thing that goes into a diagnosis is not these cognitive assessments, but when you're screened likely have dementia, then it happens more often because of maybe education. That if the assessment is very sensitive to formal education, and people have been at residential schools or have had less of a formal education. So one of the things we've been working on is the development of a Canadian Indigenous cognitive assessment. We're still working on how it should be called, but we started working with Anishinaabe communities on Manitoulin Island because they started basically wanting to do this, and really went through this path of adapting and finding a tool that they actually really liked, which came from Australia, is a Kimberley Indigenous Cognitive Assessment. Adapting and translating that tool, working on that number two took a long time, like a year of really thinking about how to adapt and use this tool, piloting it, doing reliability testing, validity testing, and now we're at the stage where we're at the implementation phase. So I'll kind of take you through a tiny whirlwind of that just to finish up so that we have some time for conversation. So the whole thing has been guided and is still guided by a community advisory council in Manitoulin, and also an Anishinaabe language group. So this language group that took the Kimberley Indigenous Cognitive Assessment, that's the KICA, translated it into Anishinaabe, and really like the purpose of that back and forth translation was meant to be a way of infusing the Anishinaabe culture and centering Anishinaabe culture in the conversation. So it actually really changed the way that things were asked. When we went back and forth between people who understood what the cognitive assessment needed to do with the community members. So we're going through this process again with other communities, and I can see what happens is people say, oh well, that might be too hard for people with dementia, we don't want to ask them to do that. And so the advisory group's tendency is to want to make the tool easier, but it has to be hard or it has to detect cognitive impairment. And other times their preference is to have a very specific question with a very specific answer, and that's actually harder, right? If you give people more space to have a range of different answers, it's easier. So we have to work back and forth to really make sure that it's doing what it needs to do in the right way. So a couple of things came up when we actually piloted the Kika. And some of them, one of the really important things that happened actually was we learned in that moment that we had to actually change a few things. And one of those things was that the way that the advisory group and the language group wanted to ask the question, like an orientation question, like where are you in time and place, is kind of the orientation questions. And that's not how you ask it, but that's kind of what it's getting at. And the question was, instead of saying, like what time is it, or what season is it, it was what is happening in the environment right now. That was the translation back from Anishinaabe. What is happening in the environment right now? Because they wanted people to be able to say, the snow is melting, or, it's time to tap the trees or whatever. But as soon as we said that in English, it brought up all these things around the impacts of colonization, because what is happening in the environment right now came like and climate change came up for people. And the first question we asked them, it ended up being less culturally safe after that whole process. So we had to, this was the really important things that happened during the pilot. And so we just had to do some really important tweaking in the piloting. Once we had a tool that worked, then we went through some pretty standard like reliability and validity testing. So we did, inter-rater reliability testing for the tool. And then so we saw strong evidence of reliability in a small sample of 15. And then we did a validity testing where we had a geriatrician assessment. So these geriatricians were actually from McMaster, and they came and did a clinical assessment, and they could just do it however they would normally do their assessment. And then we also did the Kika, and we ended up being able to do that in 55 people, the comparison of the Kika and the clinical assessment. And we found high sensitivity and specificity using a cutoff of 34. So we found the cutoff that was going to work. The tool is available to do in English and Anishinaabe, so we did the testing in both. Here's kind of what it looks like in, those orientation questions. What time of day is it right now? What time are we in right now? Is it spring, summer, fall, or winter? That's what that question became. That was originally what is happening in the environment right now. So this is kind of what it looks like. It consists of 12 chapters, and it takes about 10-15 minutes. So, I'm hearing from people who are using it everywhere, like all across Canada, and really, like, it's wonderful to see that it's actually people are expressing that it's helping. We do know, though, that it's taking language culture of Anishinaabe people on Manitoulin Island into account, and but also that experience of trauma. And I think because of that, it makes it more generalizable to other Indigenous communities. So people are finding it helpful, even though it wasn't really like made for their community. But so we are in a process of working with other communities to see, how much can be adapted and what parameters can there be for adaptation, so that many people could adapt, the pictures that are used or something like that. Our whole goal is that it leads to earlier, more accurate diagnosis and improved health outcomes for people who are experiencing cognitive impairment. And it connects the person and the family, caregivers, community, like it just helps to identify the supports that are needed. So as I mentioned, we're in that last stage now where we're working on implementation. Here we have some funding from the Public Health Agency of Canada to develop a more formalized training program. People want that, and implement it across the Anishinaabe Nation in Ontario. And then we're also working on a Kika Nakota tool in Saskatchewan and an urban adaptation in Calgary. So we are, and finally, as I mentioned, we're developing guidelines to support future adaptations and implementation of tools, working with colleagues in Nova Scotia, colleagues in Nunavut, and elsewhere, just to really think about what would those adaptations need to look like and how can we support that. So there's more information about the Kika you can get on that iCare website. It's a good resource for like tools, and you can download the Kika and all the guidebooks and amazing videos that the community members made where they acted out how to do the Kika. It was amazing. And then there's also this website that I wanted to point you to, which is we have a big research network around Indigenous dementia, and this Indigenous cognitive health program, this part of it really supports other cognitive health researchers to learn about Indigenous cognitive health research. So we have like a specific team of Indigenous researchers and who are doing Indigenous community-based research, and then this resource is for people across Canada who are working in dementia research, but are trying to learn about how to best meet the needs of Indigenous populations in that research. So it's another resource for you. I just want to say, Yahweh, thank you very much. I'm excited that we still have a few minutes for a discussion and questions. Thank you.
Wonderful. Okay. Well, thank you so much, Dr. Walker, for your very engaging and interesting presentation. I'm sure we have quite a few questions that will be coming up. And so if you do have a question, feel free to raise your hand as Fran has done, and simply unmute, or you could also write in the chat box, and we're happy to pass on your question for you. So we'll start with Fran. Go ahead.
Thank you, Peter. Jennifer, that was most interesting. A really great presentation. I just had a question about whether there's any evidence about Indigenous people who've been able to maintain their primary Indigenous language or return to it, that might be a protective factor with respect to dementia, and therefore might be more evidence to ensure that Indigenous languages are protected.
Thank you for that question. That's a really important question, and one that we tried to ask and answer. So intuitively, and like from what people tell us, and in the qualitative research, those things come through. The importance of language at a population level in terms of like risk factors and things like that, we haven't been able to look at it. And that's because the only places we know about language, we also don't know about dementia. Right. So we haven't been able to answer that question yet because of the lack of really good population level data.
Thank you.
Great, thank you so much, Fran. And sorry if I'm mispronouncing this name, Anthea.
Hi, Jennifer. That was a really good presentation. I've got various questions actually after listening to that. And I guess my first one is, and I hope I don't say this in an unsensitive way, given that I'm from Scotland and I'm not a Canadian, but the whole notion of developing these cognitive tests, which nobody likes with dementia. I've never seen people with dementia really enjoy the battery of cognitive tests that they're subjected to. And I get the need to find tests that are suitable for different people, different languages, different communities and whatever. But does it not, but by developing these tests, are we not buying into the whole notion of Western conceptualizations of dementia and biomedical approaches? I mean, I've seen in Saskatchewan, I've seen how they've used and adapted different cognitive tests, you know, using images rather than words. And I've seen them do a kind of a checkup with somebody who was remotely, who was from a First Nations community and who was illiterate, and they were finding really creative ways to assess people. But how do you reconcile that with Western ideas of dementia, medicine, knowing what, you know, is correct or not? You know, in terms of all the initial stuff you were talking about, and then developing these cognitive tests, is there not a bit of a kind of, I don't know, some kind of button up of different perspectives, philosophies, approaches, or whatever?
I am so glad you asked that question. Not because I have an answer, but because it's a really interesting question. And I think, you know, I think you're right. And that's why I wanted to start with that diversity of cultural understandings of dementia, because in some cases, like some of the ways that dementia impacts people are actually valued, right? Like people see things, and you know, people become a little closer to a spiritual nature, and that's how it's interpreted, right? Like that's how maybe things are interpreted, and so maybe there's not always something that people want to do about it. But what is really clear is that there is a lack of connection to resources to support families and communities. So this was, you know, the intention of this is to be able to communicate a need. So like PSWs are doing this assessment. It doesn't have to be like a clinical neuropsychologist or someone like that. PSWs are doing this with the clients they see through home care, and then they're able to say, you know, I've been telling you this person actually needs more services, and there's a way of communicating that need. So it fits a different purpose. It's actually really functional in some ways about getting resources and supports. But philosophically, what we have to make sure is that we're not then saying what you're experiencing in your dementia is medicalized, I guess, and there's a risk of that. So I appreciate your comments, and I think it's really something worth reflecting on, because a lot of the way that I respond to like stated needs in communities is to then go and fill that need. But at the same time, you know, really being quite cautious about the impacts, the unintended impacts that could have.
Yeah, because it's just a kind of incongruence, isn't it, really, between a Western approach to even assessing people, which isn't person-centered, and it doesn't take account of people's individual value bases, you know, the way that we do cognitive testing anyway. And then you're trying to find a way to do that that meets a kind of cultural need, but we already know that cognitive tests are not necessarily, they're valued by clinicians. And yes, if it's an access to support, but they're not necessarily something that anybody would choose to go through. And they're not sensitive, you know, most of the tests aren't sensitive enough to actually really ascertain if someone's got, you know, like the MMSE, for example, is one of the worst tests going. So yeah, it's just interesting how you've managed to reconcile all that to make it work for people. And if it's about getting resource, and then that definitely, you know, it makes sense. Thank you.
Any other questions for Dr. Walker at this time? Still have a few more minutes. Great. Well, in that case, Dr. Walker, in case folks have some questions, would you mind if we share your email so that they can get in touch at any point?
Of course, no, I'd be happy. Feel free to reach out.
Wonderful. And the recording of this will be available on our YouTube page. So I'm not sure if we're going to be able to get that in the chat just now, but I think, Alicia, correct me if I'm wrong, but you can see that on is there a link to that on the Health, Aging and Society page for HasTalks?
I think there is. I'm just trying to get to the YouTube page, but because I'm an admin, I'm getting put through the back end, but it will be available on the YouTube page, and we can have an announcement posted through our news page on the website, which I will include now.
Well, thanks so much, everyone. It was nice to meet all of you and spend a bit of time with you.
Yeah, there was one question did come in from Sharon Anderson, said, thank you, wonderful presentation. Now, how do you support Aboriginal caregivers? Big question.
Yeah, no, there's a whole bunch of work happening around that as well. For example, in the work we're doing with Fowl Hills Capel Tribal Council, there's actually like a virtual caregiver support that's being piloted, and the pilot was so successful that those same people are just continuing. So there's a huge need for caregiver support as well. So yeah, I absolutely think that that's a huge priority. Yeah.
Wonderful. Okay, I think that's all I
Just
can
like
see.
to
I don't
say
see
again,
anything.
thank you very much on behalf of the department again. That was really great. And there's a couple of questions have come in, but lots and lots of positive comments on the chat there. Yeah, lots of positive responses. I think everybody found it very insightful. So once again, thank you very much from the department.
And for those interested, you can find the link to our YouTube channel posted in the chat as well.